Go on to our next speaker, and we are truly enlightened to have with us in this very interesting webinar Dr. Rajeev Muni. He is a senior, most respected vitreoretina consultant at St. Michael's Hospital and the Kensington Eye Institute, and is the vice chair of clinical research in the Department of Ophthalmology and Vision Sciences, University of Toronto. He also leads a very active clinical research program and has keen interest in randomized clinical trials, particularly in vitreoretinal conditions. And most importantly, he's won several awards of great repute, including the 2018 Eye Physician and Surgeons of Ontario Innovator Award of the Year. And today, it's our pride to have him with us in our eye education webinar. Thanks, Ashraf, for making it happen. And he is going to take the master class, Redefining Retinal Detachment Surgery with viscopexy.
Thank you. Thank you so much for the kind invitation. And I just wanted to comment on the last presentation. I still will use sponges in certain situations where the break is right in the middle of the quadrant, where I only have to loop the two muscles and I don't have to pass it under the rectus muscles. So then you can have a single quadrant surgery and get very good imbrication and not drain. But as Hemant mentioned, if you have to pass it under the muscle, such a large sponge, then you're worried about motility issues. So I like it when it's right in the middle and I can actually just cut it so it doesn't have to go under any of the muscles. So I've used that in some cases, even in combination with vitrectomy. But anyway, today I'm going to talk about in-office suprachoroidal viscopexy, which is my recent area of interest, along with pneumatic retinopexy. And, we can start by saying, like, why do we have to look for another approach? We already have buckling and vitrectomy and pneumatic retinopexy. Why do we need another technique? So if we go back to some of our early data from a few years ago, first of all, we showed that, and this was from a randomized data set, that photoreceptor recovery was worse with vitrectomy compared to pneumatic. We also showed that a lot of patients, despite having attachment and reasonable visual acuity, a lot of patients have metamorphopsia and anisoconia, and these are real symptoms that patients complain of. If you have a 50-year-old engineer, they could be 20-25, but brutally unhappy with the outcome of the surgery. So, one key message is just that anatomic attachment is now in this new era of retinal surgery is not going to be enough, that we have to evolve, similar to how when cataract surgery started, it was just about putting a lens in and getting a white cataract out of the eye. Now it's about more. It's about, the refraction and having no glasses and distance and near and so forth. So we're in a new era where we have to think about other aspects of vision and quality. So in order to improve this, and this is what led me down the path, is understanding important mechanisms that are at play. So this is a patient 30 seconds after a gas bubble injection. So what do you see? You see a very bullous detachment up top, and in 30 seconds, all of this fluid has moved. There was no action of the RPE pump. There was nothing. It was just purely related to the mechanical force of the gas. Now, if I told you that this force is 30 times greater when you do a vitrectomy with a full gas fill, then you could imagine the extent of force being applied to this very thin elastic tissue. And so the size of the bubble impacts the amount of buoyant force that's applied to the retina and to the area over which it's applied. And we know that this is the underlying cause of retinal displacement. So when you do a vitrectomy, 100% of the time, the retina will be stretched and shifted from its original position because of the buoyant force of that large gas bubble. So the first principle, that when we were only thinking about attachment, gas is very helpful, but it exerts tremendous buoyant force to the retina. It stretches the retina and has some harm to the retina. So this is something that we have to keep in mind in our treatments. The second thing is, this is a patient where we put PFCL in over a period of 2 minutes. The break was infratemporal. I want you to remember that it was infratemporal here. We decided, because I figured out that gas is the problem, so I said, let me put PFCL in and leave it in the eye for a week and I'll take it out later. in 1 week, and then I'll avoid all gas. And what we got was the contrary of what we expected, but we got the worst displacement we ever saw. And remember, I said the break was infratemporal. So look at the vessels that are horizontal. They've all been shifted inferiorly, and the vertical vessels are all temporally, all in the direction of fluid flow. So the second important concept is that iatrogenic movement of fluid stretches the retina. And then if you fix the retina in that stretched position, it will cause retinal displacement. And this is whether you use a large gas tamponade, because now you're pushing fluid with that gas bubble and then preventing the fluid from returning because of the tamponade. Now, or it could be with drainage in a scleral buckle, because you're forcing fluid to move under the retina and then fixing the retina on the buckle. Or it could be in other, like PFCL, where you're forcing fluid to move and then you leave the PFCL in. So you've stretched the tissue and then done something to fix it in that stretched position. This is also not a good thing. So that's the second important principle. Third, outer retinal folds after vitrectomy are also more common than pneumatic. And what we've learned is that when we attach the retina very fast, these corrugations lead to folds in the retina. These lead to skip lesions in the EZ and are associated with worse vision. On the contrary, when we allow the retinal tissue to attach in a slow and gradual manner, all of these corrugations will resolve prior to retinal reattachment. So the third principle is that forced rapid reattachment is harmful. Fourthly, we know now that the outer retinal tissue varies in integrity with time. The longer you wait, the worse the outer retina becomes. So the case on the top is the best one because it's hydrated, there's no corrugations. The one in the middle is a medium 3-4 day detachment with corrugations, more structural damage. And the one on the bottom is many, like you guys might see, with long lasting detachments for many months. Some patients may come late and you're going to get atrophy. So the fourth principle, and we also know that the macular changes are similar. You get, the longer you wait, the more macular damage you get. So waiting a month or 3 weeks or 2 weeks is not appropriate for a MAC-off detachment. So the fourth principle is repair ASAP. So if you look at these four principles, what do we do in vitrectomy? We rapidly reattach the retina, we forcefully move fluid, we use a large gas bubble, and we have to wait until we can access an OR. All four of these things are harmful. I just showed you evidence of that. And yes, we can put the retina back in place, but we don't do it in a very good manner. And this is partly responsible for the symptoms that we are seeing. So it was after understanding these four important concepts that I thought that there has to be a way to fix a detachment immediately in the office without gas, without drainage, and to allow the retina to attach slowly. And the best approach is a scleral buckle with non-drainage. But scleral buckle has fallen out of favor in some ways because of teaching experience. Also, it is a fairly invasive procedure. I mean, there's some surgeons who call it barbaric even. And, you know, of course, it's elegant from an internal perspective, but, you know, we've all been there pulling on muscles, cryoing, deflating the eye, injecting it. A patient's eye is swollen shut the next day. It's a significant surgery. So how can we address all of this? So this was the first case where I ever did this procedure. I just took a Helon 5. I took some IV tubing. I taped on the IV tubing with a steri strip. I assumed the retinal thickness was 1 millimeter. This was a supratemporal RD in a pseudophakic patient with no visible break. But as the speaker, I think Aditya mentioned, I knew where the break should be based on Linkoff's rules. So I'm now indenting with the needle and the guard, and my assistant tells me, oh, there's too much resistance. So I know I'm in sclera. So then I have them continue to push while I push my needle in a little harder. And as the needle enters the suprachoroidal space, because they're kind of already pushing, it flows and it creates a bleb. So here's the concept, which I'm sure you guys are now familiar with. This is an IV tubing on a needle that I indent. and the assistant is pushing. When the needle enters the suprachoroidal space, the gel flows, no gas, retina attaches quickly, done in the office in a 5-minute procedure when everything goes well, and it makes perfect sense to us who do a lot of buckles. So this was the case, a supratemporal RD, and I did this without ever seeing the break. And the next day the retina is attached. So imagine my excitement, in this case, where the patient went to work, he played tennis, he walked around, he could fly in a plane if he wanted, and he comes back without doing anything, and he's attached. So I knew at that moment that this is going to be a game changer if the technique can be perfected. This was the OCT on baseline. Day 1, you see attachment. Day 2, loss of the CME is gone, already getting recovery. And here you can see, even though there was no visible bleb postoperatively, you'll see here, like I didn't get a great bleb actually. I was using Provisc for this first case because I was scared to use something longer lasting. But you can see, even though there was no visible bleb, you can see the gel in the suprachoroidal space here. So even a minimal indent allowed the retina to attach. And here's an OCT scan which shows the gel going away, or sorry, the gel being visible as you're scanning through the scan. So it actually went quite posterior and was quite broad. It was like a low-lying buccal with very minimal indent. Now, are we going to get retinal displacement that we see in every vitrectomy? Of course not, because we're not using any gas and we're not forcefully moving fluid. We're not fixing the retina in any position. Now, we then looked at suprachoroidal imaging in normal eyes, in healthy eyes, in retinal detachment eyes, and realized that the suprachoroidal space is visible, and it's not always just a potential space. And in fact, in retinal detachment eyes, we were seeing it more, the suprachoroidal space. And in fact, as the retinal detachment resolves with pneumatic, we were imaging the suprachoroidal space and showing the reduction in depth. In other words, when the retina is detached, there's increased uveoscleral outflow. This is a potential space that's been engorged already. And so we have an opportunity for a therapeutic intervention because not only is there a space in general, a potential space, but that space is already expanded. It's just waiting for us to put something in there because it's already swollen. And we showed that the thickness of the suprachoroidal space in retinal detachment eyes versus the fellow eyes was greater. So today I'm going to share with you the most recent publication in JAMA Ophthalmology where we demonstrated 6 consecutive cases. They all had temporal or nasal breaks, and we'll talk about why, but that's because with that technique, that's what I was able to properly access in office with a direct needle and entry where the needle's perpendicular to the sclera. In all cases, I could create a bleb, and 5 out of 6 cases required no other intervention. 1 patient failed. All immediately resumed normal activity, and the Helon 5 was the viscoelastic I'm now using, which lasted on average 16 days. This is a patient, a cleaning lady from the Philippines who came from the Philippines and arrived to my office that day on her return. She had a large temporal break, MAC off for a month. This was immediately after the 5-minute procedure. I put the gel right underneath the retinal break. You see the gel here in the suprachoroidal space, and the laser was done on day 1. You'll see in these cases, you'll notice that I've put a lot of laser in. It's not my usual style to put this much laser around a break, but I was worried because I didn't know how long the gel was going to last, and I knew that I have to get not only the laser, but the adhesion has to form prior to the gel going away. So this led to excessive laser, I feel. Now, of course, we see again no displacement. Here's the baseline images. You see the attachment and the excellent recovery of the photoreceptors. Here's the final kind of picture. This was a 50-year-old male with Parkinson's, temporal break, stage 3B detachment, viscopexy under the break, attached the next day. No change in activity, no positioning, nothing. This was the laser that we applied, and again, excellent recovery with no displacement. This was the third case. He's from India, Actually, his nephew's a retina specialist, and he was sent to me for a pneumatic. He had a nasal detachment, supranasal break that was hard to see on this picture, pseudophakic. And here's the procedure being done. So I do a subconjunctival anesthetic. Again, I'm holding this Helon 5 guarded needle IV tube. I'm initially just pushing very little. Okay, I'm putting the needle there, but I'm not pushing very hard, just so that I can see the beginning of my indent. So now I'm oriented. I know where I am. Now my assistant tries to push, and they say it's going subconj. There's too much resistance, and I use that feedback to know where the needle is, and I either push more or push less or accordingly. So here I push more, and you can see a little subconj bleb forming around the needle there. But internally, I'm also seeing the gel flowing. So it's probably a little bit is refluxing and it's going in. And you see immediately after the bleb that's formed, and you can see the laser starting to be applied, and at week 4, a full attachment with laser. And here you can see the progression. No displacement again, of course. This is a 62-year-old male, temporal break. Again, I think I'll just skip the video. It's the same thing. Here you see day 1, the break done immediately after. No displacement.
You had a suprachoroidal viscopexy.
How does the patient feel about the whole thing?
Injected this liquid between the layers of the eye to close the tear, and then the retinal detachment resolved on its own after that. I just wanted you to describe like how the procedure was. Like, so on the first day when you came in, we diagnosed you with the detachment, and we did that procedure. Can you just kind of explain how it felt for you and what the experience was like, just so we can get a sense of that?
Yeah, the liquid going in, it was just a lot of pressure for just a few seconds.
Okay.
So the pain wise was just a few seconds.
Okay. And
I think that was the key point I wanted you to get, that there was a lot of pressure for a few seconds. This was his experience with the procedure. This was a 39-year-old male with an ICL. Didn't want a buckle or a vit, and I did the viscopexy. He had 2 breaks inferiorly. I put the gel under the break, and then I started to do laser over a couple of days in this case, and we were able to fully attach. Now this is the one that failed. This patient had a more posterior break temporally, and my buckle, I wasn't able to get far back posterior enough, so the buckle was too anterior. If I had more experience, I would have gone in and put a second, I would have done it again another day, probably. Or but I was scared to do that. So I just did a pneumatic, and then it attached. What were the adverse events? One patient, as I mentioned, I had this tendency to do too much laser on these cases. One patient, interestingly, got a choroidal effusion in the opposite quadrant of the viscopexy. We never did anything in that quadrant, but the patient got a choroidal effusion, so that resolved with drops. Now, after these original cases, I've done additional things where I've now done this in combination with drain. So this was a patient with a 2-year detachment, 2 inferior holes, and I was worried about how long the fluid, the gel would be there, and I felt I had to drain this case because this woman I actually knew for a long time because her father died and she didn't want the buckle done, and whatever reason, she basically came to me, then came back a year later, then came back like 2 years later, and then finally she allowed me to do the surgery. And I knew that the fluid was going to be thick, and it had to be, I thought I had to drain it. So I took the patient to the OR. I did the viscopexy just with an indirect, and then my fellow just grabbed the limbus and rotated the eye for the infranasal area. I did one little radial slit, and then I did a little cut down, cauterized, and drained. And so there was no looping of muscles, no opening of the peritomy other than that little radial incision. And I did that after I put the gel in. So this was immediately after the gel. Well, this was day 1 because I didn't have a photo in the OR. But this was the gel, and now the retina's attached after the drain, which was done infranasally. And then I did the laser on day 1 in the office. Now, look at the OCT progression. This is what she started with, and this was on day 1, I believe. And here, sorry, my slide is showing. Yeah, this is month 1. And over time, she actually got excellent recovery. She returned, this was 20/80, I think, at month 3, but now she's at month 8, and she's like 20/30 or something like that. Now, what about as a rescue for pneumatic? This was my colleague, Dr. Phil Altamari at St. Mike's. He did this infratemporal pneumatic, which we do all the time, and we can get them to work, but 2 bubbles, side positioning, blah, blah, blah. But this one didn't work, so he sent it to me, and I put the gel in under the brake. And now I could put the patient face down to get the posterior aspect of the brake, and I had the anterior brake covered because of the gel. And then I started to do laser, and here you can see the retina attached with the nice laser around the brake. I'll end with this combined scleral buckle. We know that when we do a vitrectomy with inferior brakes, they don't always work because patients can't position with gas, and inferior brakes can fail. And we also know there's a problem with the tamponade. So, I envision a time when even vitrectomy surgery will end up having viscopexy done. And the reason is because we can avoid potentially using tamponade, we can avoid positioning, we can improve success rates because we're closing the brake a different way. We're lasering it, and then instead of tamponading from the inside, we're going to use the buckle from the outside that can be put in immediately at the time of surgery. So I'll skip this. This is in our JAMA publications, but just shows how we make the needle. It's all there online. But I just wanted to show you this case. So in this, I usually do it manually because I like the feedback. But in this case, I tried it with the VFC. So I put it into a 10 cc syringe. I had the VFC tubing. I had my needle that I made. This should say PSI. There was 50 PSI that we used. And here there's 2 infratemporal breaks. And I went to air, I did the laser, and then I'm indenting and pushing the pedal. Now, when I was in sclera, the back end blew off one time. We hate when that happens with silicone, it startles everyone. But then I locked it properly. I put it in the sleeve and everything. And here's the bleb without me indenting. And you can see the nice, beautiful bleb underneath the brake. And this was post-op. So in summary, it's a temporary suprachoroidal buckle. It's minimally invasive, no drainage, no tamponade, no positioning. Can be done immediately in the office. And I think it'll maximize our outcomes with all techniques, buckle, vit, and pneumatic. And it'll be a new standalone procedure. And all the credit goes to Jules Gonin and Custodes. They told us to find the brake, treat the brake, don't drain, and that's all you need to do. Everything that came after that was a lot of sexy equipment and stuff, but that doesn't really help in terms of retinal reattachment. And even Machamer said the retina wants to heal itself, and it will if you don't do too much to it. And I think this is going to be our new era for retinal detachment surgery going forward. And you will see how this fits into everything. But we're currently developing a device now to make this a more elegant procedure than what we're using right now. I would consider this as a proof of concept that if you can deliver this in the right space and without complications at the right time, that it'll be a game-changing treatment, but it requires a technological innovation in order for all of us to be able to safely do this in the clinic. So this is what we're now working on, and I hope to share that with you over the next year.
Congratulations, Doctor, for the wonderful, passionate talk you gave, and I'm sure there's a lot of learning which will come through this. So on to you, Ashray.
Sir, firstly, thank you for redefining a lot of things for us, especially with all your more than 100 publications on retinal detachment and the RPE pump theory. So my only question is, yes, going suprachoroidal can be difficult. It's essentially slightly an obscure procedure where you don't know exactly where you are unless you visualize. So is there any fail-safe methods where you can prevent perforation, because essentially why we included in our buckle up was we are always talking about external buckles. So this is a viscopexy is an internal buckle, and it's a temporary buckle which will elevate all the things which you told. So can you just throw some light on it, sir?
You're absolutely right. This is all about now. We've shown proof of concept. Other people have shown proof of concept. We've shown proof of concept in the office. It's all about safety now, safety and ergonomics. And so, what we feel is that you need 3 or 4 things to make this a better technique. Number one, we need illumination of some sort. So we're putting a light at the end of a depressor, at the end of a probe, that will show you exactly where you are internally, through transillumination. Number one. Number two, the scleral thickness is variable in every patient. And so you need a variable length needle. It cannot be 1 millimeter or 9.9. Like, who knows? There could be scleral malacia, there could be thinning, there could be anything there. So we need to know, what the needle has to be variable. It has to adapt to the location, to the patient, to the culture, ethnicity, whatever. So that's the second thing. The third thing is that it's hard to push this gel through a 30 gauge needle. So you need a motorized infusion, foot pedal controlled. And number 4 is that the motor must be pushing the gel as the needle's advancing through the sclera, so that as soon as the needle when it's intrascleral, nothing's going to come out of the needle. The second it hits the suprachoroidal space, without you even seeing it, the motor is already pushing the fluid, so that immediately the choroid will be pushed away. And the reason I know this is because when I do these manually, I have never let any of my fellows do this procedure, by the way, because I think that you need to have tremendous control with the indirect, with your needle. And this is something that I think you need like 5-10 years of experience before you get. And so my fellows are pushing on the gel, and I'm very astutely looking at their feedback. Like, is it flowing too much subconj? Is it not flowing at all? Is there a lot of resistance? Is there medium resistance? And I'm using that to gauge where I'm doing. And so what I want to do is I want to convert that into a more predictable process where you have a motor that's pushing the gel as the needle's advancing, so that once the needle hits the space, there's certain amount of newtons or dynes of force that are already being applied, that the gel will flow. So these 4 things are what we're innovating in the device.
Sir, I think I've realized that we should have a separate session on this to extract the full gravity of this, gravitas of this topic. But Dr. Rajesh, your thoughts on using viscopexy? I know you are been doing all these surgeries. If you have any thoughts on the technique, sir. Dr. Rajesh?
Yeah, thank you, Ashray. We have been doing suprachoroidal viscopexy for quite some time, and we had our initial experience like what was initially prescribed. So what we do is usually do a cut down, open into the suprachoroidal space, and we used to inject the viscoelastic. See, basic issues is like back in India, like most of the problems is we don't have a consistent viscoelastic, and the basic problem that we faced was the retainability of the viscoelastics. How long it's going to retain, it's a questionable thing. See, all of whatever Dr. Rajeev Muni has said is very elegant. I'm not saying no. But what is the problem is the uncertainties from the step, other than the localization of the break to the healing of the break, everything is a bit uncertain. Amount of viscoelastic you are injecting is uncertain. Whether it's going to index.
How much gel were you injecting when you were putting it in, and which gel were you using?
So we were actually like it was not a very well defined term, because it was almost about 5-6 years back that we started doing this. And there was, once we entered into the suprachoroidal space, obviously the amount of fluid that was gushing out. And then we were very careful in injecting, because we didn't want to hit the suprachoroidal space and cause a lot of bleed. So all these were a thing. So we used to look inside, not continuously like how you said, because the single person used to inject, look inside, and then come back and then inject. So only about twice we could go on either side and inject it. And whatever the space that it used to cleave in the suprachoroidal space, we used to inject. That's it. So only problem was we used to get an indent, but the indent was very, very variable. In some patients, it used to be very high. In some patients, it used to be very low. So we didn't do the way that you have described, that you're seeing inside and somebody else is injecting it. So that was a bit of a, I don't know how to go about, commenting upon that. But a few patients they had very good results. And the other end, like, how does this work in a post, vitrectomized eye? I don't understand, because any buckle for that matter, it doesn't really work in a patient who has vitrectomized. Like, for example, if I do a vitrectomy and it fails, I don't do a buckle because the essence of vitreous which is inside is not working. So how does the suprachoroidal viscoelastic work in a vitrectomized eye? I don't know. So all these are ifs and buts. We had a one share of success rate with this, but it was not consistently the same. So we did shelf itself very few cases, and even now we do it in cases which it's very difficult to manage, and give a chance, as you told, and see if it doesn't work, then other options are always available. But it was the only issue that we always felt is right from the after the localization of the buckle, which is very much clear, and post that everything else is a bit of, you cannot titrate it the way you want, like how a buckle, how very, madam put it across, Padmaja madam told that you have 6 mm, 8 mm, whatever, and this is the dent that I can get. So that kind of a consistent thing you cannot achieve with viscoelastic. That's the biggest issue.
Yeah, I just a few comments on that. So first of all, in a vitrectomy, I've actually, before I was doing this, I was doing something called minimal gas vitrectomy or minimal gas vit buckle to reduce the risk of displacement. And in fact, I know a buckle works in a vitrectomized eye because I've done a full vitrectomy and I have a 6 o'clock break, and I'll put a segmental sponge under that break. And then if, let's say I have a 12 o'clock break as well, I'll put a little gas bubble, a small, like 0.6 cc bubble of expansal SF6 for the superior break, and I'll position them upright, and the superior break will close from the buckle, and the inferior break will, from the pneumatic, and the inferior break will close from the buckle. In fact, I've even done vitrectomies with no gas and putting a segmental buckle on the break, and the retina will stay attached. And the reason is because there's two concepts about how a buckle works. Number one is that we hear this about it's rotating the wall of the eye, and the vitreous plugs the break. This is one theory, but never been proven that that actually happens. The second theory is that when the indent from the buckle changes the dynamics of fluid flow, which I believe is the major factor. And so when you put something underneath the break, there's the Bernoulli's principle, the fluid is flowing by, and it creates a high pressure and a low pressure system. I'm not a physicist, so I don't fully can explain it to you as elegantly maybe as an engineer, but essentially the flow of fluid across the tear is altered by the anatomy that you've changed. And so so I believe that that's the most likely and because that's why I've seen it work in vitrectomies where I'm not even using any gas. That's the first thing. The second thing is we've used a very consistent protocol of using Helon 5, which is the longest lasting agent. We know it lasts about 14 days, and we are putting in the full syringe, 0.6 ml, under direct visualization. So I feel like these are some of the things, and I'm aware of the work in India with the cut down and this, and I agree with you in the sense that if I was already going to the operating room and I was looping the muscles and I was making a scleral incision, then I would say to my fellow, like, why don't we just sew on a sponge here? We're already, what is the advantage? To me, where this technique will help is if we can do it right away in the office in a very, very minimally invasive and elegant way. But I completely agree with you that there's uncertainty with the current approaches. And I don't want to sound like I'm advocating that what I've showed you is something that everyone should go out and do today. Like, to me, this is a proof of concept that it can be done, and we need better technology to make it done in an elegant and safe manner.
A few points to say agree with you and disagree also, sir, respectively. The one thing is like the whole concept of buckle we had been advocated or thought is It's not the fluid part. The vitreous which is pulling onto the flap and is causing the brake to detach. So the vectors are reversed, and now the vitreous is pushing the brake. That is what I had understood. Maybe it might be wrong or whatever it is, as you told. The second concept is like, now that the whole point of we doing a viscoelastic was not for anything else, to avoid the refractive error that we get. And since Melanie's bubble was also, the link off balloon was there, which had already been proved that, you can do a temporary buckle and get away with it. But the positioning of the thing, the, sticking of the balloon over there, it was all of a very messy procedure to the patient. So that's why viscoelastic has come in. So one is, yes, as you rightly pointed out, it's a very non-invasive part of whatever it is in the office we can do. But the whole point is, as you rightly pointed out, you're not injecting anything inside. He can fly over, he can do everything, he can become, as soon as ambulatory as possible. All those were the key essentials of doing a viscoelastic.
Thank you. Thank you very much. Left with lot of thoughts to think over it.